Okay, everyone, thank you again for joining us. My name is Suzanne LeBlanc, and I am the Director of Clinical Relationships at the Focused Ultrasound Foundation. I am proud to partner this webinar along with Yanni Wattenmaker, the Executive Director of Breast Cancer Alliance. In honor of Breast Cancer Awareness Month, we are thrilled to present this webinar, Advancing the Frontier, Novel Immunotherapies for Breast Cancer Treatment. Although advances in diagnostic imaging and increased public awareness has improved earlier detection of breast cancer, the medical community continues to develop novel strategies to decrease the need for invasive surgical procedures, minimize the side effects from radiation therapy, improve the targeted delivery of chemotherapies, and importantly, harness the power of the immune system to improve clinical outcomes. The presentations you will hear today discuss the overlap of Focused Ultrasound Foundation and Breast Cancer Alliance sponsored research. On the Focused Ultrasound side, there are about 15 clinical trials addressing breast cancer at various stages of completion. Yanni?
Thank you, Susie. It's always a pleasure to collaborate with you and the Focused Ultrasound Foundation. BCA also aligns with many of the missions of your foundation by increasing awareness in the community, providing educational outreach, such as this webinar, and funding preclinical and clinical research. One of the three prongs of the mission of Breast Cancer Alliance is dedicated to just that, to exploring potentially game-changing, life-saving breast cancer research that does not yet qualify for federal funding, and helping to get those concepts launched, to help scientists get the funding they need to demonstrate their proof of concept, and ultimately get new pharmaceuticals, new approaches, and new technology into this much-needed arena.
Well said, well said. And before we get started, just a few technical items. If your connection is lost, please simply log in again using your registration link. Following the 4 short presentations by our panelists, we will have a moderated roundtable discussion and question and answer session. So please submit your questions using the Q&A function at the bottom of your screen.
The first 2 presentations will showcase researchers that are using uniquely engineered antibodies and anti-drug conjugates to target breast cancer tumors, both of whom have received funding from BCA. First, we will hear from Dr. Paulina Weitzenfeld, Research Associate in the Molecular Genetics and Immunology Laboratory at Rockefeller University. Her specific antibodies led to potent anti-tumor responses in preclinical studies with fewer toxicities, leading to a first in-human phase 1 clinical study demonstrating effective and systemic anti-tumor responses. This has now prompted ongoing phase 2 clinical studies. Then we will hear from Dr. Andrew Davis, Assistant Professor of Medical Oncology at Washington University in St. Louis. He will summarize his phase 1 clinical trial using a newly constructed antibody-drug conjugate.
Great, thanks, Yanni. And the last 2 presentations will highlight research performed with Focused Ultrasound and Immunotherapies, which received support from the Focused Ultrasound Foundation. Dr. Natasha Shaybani is an assistant professor in the Department of Biomedical Engineering and research director of the University of Virginia Focused Ultrasound Cancer Immunotherapy Center. Her presentation will highlight how various mechanisms of focused ultrasound can potentiate the efficacy and safety of immunotherapies for local, systemic, and even breast cancer metastases to the brain. Then Dr. Patrick Dillon, an associate professor of oncology in the Division of Hematology Oncology at the University of Virginia, will discuss his translational clinical research with focused ultrasound augmenting immune-mediated control of breast cancers. So Dr. Weitzenfeld, please start us off.
Hello, everybody. Thank you for having me. My name is Paulina Weitzenfeld. I'm a research associate at the Rockefeller University. I'm very excited to share our data about enhancing antibody-mediated immunotherapies by FC engineering. I'd like to start by sharing the story of patient 14. She's a participant in a phase 1 clinical trial that we had, and she was one of our complete responders. This lady was 67 years old. She has been diagnosed with metastatic breast cancer for over 20 years. She had history of metastasis to her liver, her lungs, her ovaries, and she underwent multiple procedures to resect those lesions. She also received multiple lines of therapy, pretty much every chemotherapy in the books. And when she presented to the trial, she had metastasis in her axilla and in her liver. This is how her underarm looked before treatment. And as you can see by the 4th cycle, everything was completely cleared. We also looked at her internal metastasis, and those were also shrinking. And finally, by the 5th cycle, all of her cancer biomarkers went back to normal. So what treatment did she receive? What is this clinical trial? So the drug that she received is called 2141B11. It is an Fc-engineered agonistic antibody that targets the checkpoint CD40. What does that mean? Well, the immune system is all about balance, and checkpoints regulate the immune response. Some of them are inhibitory checkpoints that we want to block, and some of those are activating checkpoints that we would like to agonize. And today we will focus on CD40, which is an activating checkpoint. It is expressed predominantly on a subset of immune cells called antigen-presenting cells, such as dendritic cells. It promotes activation and maturation of those cells, and the goal is to activate CD40 to initiate an anti-tumor immune response. Now, CD40 targeting antibodies have been tested in the past, but with little success. This is a partial list of some of those drugs, but there were a few challenges. The first was efficacy. They led to stable disease or partial response at best. And the bigger problem was adverse events. The drugs were just too toxic. So most of these had to be discontinued. So we thought, how can we improve the anti-tumor activity of anti-CD40 antibodies while minimizing adverse events? The first thing we did was change the administration route. Instead of giving the drug systemically, we're going to inject it straight into the tumor so it can concentrate where it is needed the most, inside the tumor, while minimizing adverse events in remote organs. And the second was to engineer the Fc portion of the antibody. Antibodies have two main parts: FAB, which binds to the target, and Fc, which interacts with other immune cells by binding to Fc receptors. Fc receptors are also expressed in immune cells. There are several activating Fc receptors and one inhibitory Fc receptor. And past findings from our lab have shown that for optimal activity, anti-CD40 antibodies require strong binding to the inhibitory receptor FcR2b. Why is this interaction so important? So the thing is that efficient activation of CD40 requires the molecule to undergo trimerization. And that has been challenging to achieve when we're using therapeutic antibodies, because they mostly bind to the monomer. But when we use Fc-engineered antibodies, the interaction between the Fc and the FcR2b forms a scaffold. That scaffold helps the CD40 to undergo trimerization and promote the downstream signaling in the expressing cell. The anti-CD40 antibodies that were evaluated in the past were not optimized for binding to FcR2b. So we employed Fc engineering techniques to enhance binding to FcR2b. Here we have an anti-CD40 antibody. The clone is 2141. And we can introduce different point mutations to its Fc to generate a panel of variants. Today we will focus on one of those variants called V11. And it has 5 point mutations and a 96-fold higher binding ability to FcR2b. So our proposed mechanism is as follows. In the past, non-Fc engineered antibodies would bind to CD40 on dendritic cells, but they would minimally interact with FcR2b. So the CD40 wouldn't trimerize, so nothing would happen down the line. But when we use Fc engineered antibodies like our 2141B11, the scaffold is formed, there is efficient CD40 trimerization. The dendritic cell will become activated, it can present antigens to the T cell will become activated, and can go and do some tumor cell killing. So can we model clearance of breast tumors by anti-CD40 antibodies in mice, as we've observed in patient 14? So in order to answer that question, we used E0771, which is a very aggressive breast cancer model. Our experimental setup is very simple. We inject the cells into the memory fat pad, and by day 14, when the tumors have formed, we give them 4 doses of our antibody, and we follow up tumor growth. When we used non-Fc engineered antibodies, you can see that it didn't matter when the antibodies were given systemically, IP, or straight into the tumor, IT, all tumors grew. So non-Fc engineered antibodies failed to induce tumor clearance. But will Fc-engineered antibodies demonstrate a more profound anti-tumor activity? The problem is that there are differences between mouse and human CD40 and between mouse and human Fc receptors. So using wild-type mice just don't allow us evaluating antibodies that are designed for patients for the clinic. So our solution was to generate a new strain of mice, human CD40, human FCR mice, that have the human genes for CD40 and Fc receptors, but don't have the mouse genes. So when we repeat this experiment in human CD40 human FCR mice and we treat them with our Fc-engineered antibody, all tumors regress. So 2141b11, an Fc-engineered anti-CD40 antibody that is designed for the clinic, leads to 100% tumor clearance. But does it lead to generation of long-term immune memory that can protect mice from disease recurrence? We added an extra step to our experimental design. On day 90, when the mice have been tumor-free, we call them primed mice, we re-challenge them with a 5x dose of tumor cells, and we follow up tumor growth without any further treatment. And you can see that while naive mice grow tumors, the primed mice do not. So 2141 of B11 leads to the development of immune memory, protecting mice from tumor recurrence. But since the antibody is administered locally into the tumor, can it eliminate remote, non-injected lesions like we've seen with the metastasis of patient 14? We did a bilateral tumor challenge to answer that question. We inject 2 tumors into 2 mammary fat pads, and this is how it looks before treatment. We inject only one of the tumors, the larger of the 2, and we follow up both. And you can see that both tumors, the injected and the non-injected, both regress. And this is the same mouse on day 60, completely disease-free. So local administration of 2141v11 generates a robust abscopal effect and systemic immune activation without measurable toxicities that I won't show just due to lack of time. So to sum up, Fc-engineered anti-CD40 antibodies lead to primary tumor clearance, an abscopal effect, and long-term immune memory. Our in vivo systems allow modeling the anti-tumor activity, the toxicity, and the impact on the immune system of anti-CD40 antibodies. The results from our phase 1 clinical trial suggest that the antibodies are well tolerated and can lead to complete responses. And we already have multiple trials underway for different cancers. And the take-home message is that Fc engineering unlocks the full potential of antibodies and transform their therapeutic impact. I'd like to thank my mentor, Professor Jeffrey Ravitch, the clinicians that led the trial, all Ravitch lab members, our collaborators from Memorial Sloan Kettering, the trial participants, the BCA for my funding, and our other funding agencies. And thank you for listening.
Hi, my name is Andrew Davis. I'm a breast medical oncologist at Washington University in St. Louis. And I'm going to be talking to you today about some work that we've been performing over the last several years, evaluating the combination of 2 different drugs, one of which is called trastuzumab deruxtecan, which is an antibody-drug conjugate, and the other is an oral tyrosine kinase inhibitor called neratinib. We evaluated these drugs ultimately in patients with HER2 alterations. To take a step back, I want to explain what a phase 1 clinical trial is and how we got to this point. Phase 1 clinical trials are the first trials to evaluate either a single drug or drug combination in patients. And before we get to that stage, there's extensive evaluation to look at both efficacy and safety of the drugs using preclinical testing. At the stage of the phase 1 clinical trial where it's evaluated in patients, the primary assessment is for drug safety, to make sure that the drug or drugs are tolerable and can be safely administered in patients. But of course, in addition to safety, we also want to look for signals of efficacy. And that means basically finding drug or drug combinations that lead to patients living longer and living better as well in terms of improved quality of life. I want to explain what antibody-drug conjugates are, because this may be a new term to some people in the audience. So if you look at the top right, basically this is an antibody shown in green with a linker in blue, and attached to that linker are basically chemotherapy molecules. And it's a form of therapy that is aimed to deliver a chemotherapeutic in a targeted manner. So if you now look at the bottom left, you see these antibody-drug conjugates or portions of these traveling in the bloodstream. They then have a signal to target a specific antigen on a tumor. And once the antibody-drug conjugate is internalized by a tumor cell, it can then lead to cytotoxicity, or basically killing the tumor cell. And then that chemotherapy, what we call payload, can then travel or diffuse to nearby cells, also leading to killing of nearby tumor cells. The antibody-drug conjugate that we evaluated in this clinical trial is called trastuzumab deruxtecan. And as you see on the left, it has that same structure of an antibody with a linker and then a chemotherapeutic payload attached. What makes this antibody-drug conjugate interesting and very effective in certain patients is that after the inhibitor enters the nucleus, leading to cell death, it then has what's called a bystander effect, where it can the payload can permeabilize to nearby cells, leading to cell death and killing of other tumor cells. This antibody-drug conjugate, trastuzumab deruxtecan, has been evaluated by itself in a number of clinical trials in breast cancer as well as other tumor types. But I want to highlight in particular two really landmark clinical trials in breast cancer. The first was published in 2020, and this utilized trastuzumab deruxtecan in patients with HER2 positivity or overexpression. And that led to really impressive results with the average duration of patients on therapy of 16.4 months, what we call progression-free survival. On the right, what you can see is a subsequent trial that was published in 2022, extending the use of this drug to patients at lower levels of HER2 expression, what we would call HER2 low expression. And while the trial was very promising and very exciting for patients with HER2 low breast cancer, with a median progression-free survival of about 10 months, you can note that the duration of response, or how long patients were on therapy, was lower in patients who had lower levels of HER2 expression. This led us to evaluate a combination therapy of neratinib, which is an oral drug, with trastuzumab deruxtecan. And we started with preclinical models. So this is what's called a PDX, or patient-derived xenograft model. And essentially what this model was, it takes a sample from a patient, it's inserted into a mouse model. And what we showed in this model, or these models, is that when we use the combination of these two drugs, there was a synergy, and the neratinib led to increased uptake in a targeted manner of trastuzumab deruxtecan. With further experiments, we wanted to demonstrate that in mice, the uptake of this synergy was in a targeted manner. So what you can see on the left is that there's an increase specifically in the tumor with the neratinib, but if you look at a variety of other tissues in the mice, whether it be blood, heart, lung, brain, etc., the antibody-drug conjugate was not increased in areas where the tumor was not located. Ultimately, that led us to the hypothesis that the combination of neratinib with trastuzumab deruxtecan would lead to an enhanced anti-tumor effect with manageable toxicity in patients with HER2 alterations. At Washington University, we led the initiation of this first-in-human phase 1 clinical trial that's run through the National Cancer Institute. And we've had a lot of excitement and great collaboration and participation by multiple sites as listed here from cancer centers around the United States. Here's an overview of the design of the clinical trial. I'm just going to give you a couple of key pieces of this. So there are two portions, what's called a dose escalation phase, where we use various doses of these two drugs in a very well-outlined manner. to determine what's a dose that's both safe, but also showing signals of efficacy in patients. On the right is what's called a pharmacodynamic cohort. And that's going to be specifically looking at and measuring in tissue whether the neratinib leads to increased uptake of the T-DXd trastuzumab deruxtecan in patients. And I'm happy and really excited to report that part 1 of the study has now completed. We've shown that the combination of the drugs is safe, and we've seen some really exciting responses, both evaluating this drug combination in breast cancer patients, but also various other types of cancers with HER2 overexpression or mutations. The final piece I want to mention is we are evaluating markers or biomarkers to evaluate in the future what patients may benefit from the trastuzumab deruxtecan alone versus patients who really need that second drug to get a long-lasting, durable benefit on therapy. And with that, I want to thank everyone in the audience for listening, all the patients and their families for participating in the research, the NCI, Dr. Ron Bose's laboratory for performing the experiments in the preclinical setting, and of course, and importantly, the Breast Cancer Alliance for helping to fund this work. Thank you very much.
Hello, everyone. My name is Natasha Shaybani. I'm an assistant professor of biomedical engineering at the University of Virginia and research director of UVA's Focused Ultrasound Cancer Immunotherapy Center. It is a pleasure to be participating in this webinar during Breast Cancer Awareness Month. In this talk, I'll be sharing a bit about our group's efforts to potentiate breast cancer immunotherapy with focused ultrasound. The figure on the right displays the many conventional and novel therapy options for breast cancer treatment. Many of these options, albeit effective, pose safety and toxicity risks or are ineffective against metastases, which we know are a chief cause of cancer morbidity and mortality. Immunotherapy drugs are promising for overcoming some of these limitations to traditional cancer treatment by enabling more selective targeting and eradication of both primary and distal tumor cells by the immune system. Given that the full potential of immunotherapy has not yet been realized in breast cancer, much attention has been turned to strategic combinations in recent years. My group is coming at this grand challenge with patient survivorship at the core of our mission, which brings us to the use of focused ultrasound technology as part of that strategic combination effort. Focused ultrasound is arguably unparalleled among the treatments shown here in this figure, as it offers a simultaneously non-invasive, non-ionizing, and highly precise intervention approach, thereby harboring very little safety or toxicity risk for patients. Focused ultrasound, because it relies on the physics of sound waves, is also a highly tunable technology, enabling a uniquely versatile selection of mechanisms of action. These mechanisms of action are under broad exploration in our lab for multiple oncology indications, including breast cancer. This slide just summarizes the many branches of my lab's work in FUS immuno-oncology. Today, I'll just provide 2 vignettes highlighting our emerging work on in situ vaccination and primary breast tumors and CAR T-cell therapy in brain metastases. The first story is rooted in the use of focused ultrasound for thermal ablation. And thermal ablation is the most clinically advanced mode of action for FUS technology, the basic principles of which are illustrated here. I draw your attention to the histology on the right, where we've ablated murine breast tumors, and you can appreciate the extensiveness of coagulative necrosis and apoptotic cell death following ablation. You can also appreciate the upregulation of heat shock protein, or in this case, HSP70, in locations adjacent to those bearing direct evidence of cell devitalization. We've seen consistent evidence for this, which we term the periablative zone in our studies. And we've also done assessments showing in vivo elaboration of other immunogenic cell death signatures like ATP release, which I'm not showing here. Taken together, these observations suggest that thermal ablation could be immunogenic, but we've learned from our past work that localized insult with thermal ablation alone is largely insufficient for engendering immunologic control of breast tumors. So we've recently turned to anti-CD40, a co-stimulatory immune agonist and common cancer vaccine adjuvant, as a strategic combination for elaborating systemic control. What I'm showing you all is a snapshot of our findings thus far, where we've put this combination to the test. These are outgrowth data for treatment of murine luminal B breast tumors, which we've also recapitulated in mice with triple negative breast tumors, which is not shown here. What you see in these data is that the combination of thermally ablative, or TFUS, and anti-CD40 offers superlative growth control and a marked survival benefit. This growth control in the combination is also notably underscored by complete responses in some mice, the proportion of which you can see in green on the left-hand stacked bar graph. To probe immune memory, we've performed an aggressive contralateral rechallenge in these complete responders. And what we have seen is that they reject rechallenge. And also on peripheral blood sampling, we see that they bear evidence for effector and central T cell memory in their circulation. So we're continuing to perform immunoprofiling to better understand what is driving the effect in this combination therapy. But in the meantime, we're also doing some mechanistic studies to probe causality. I show one example here, which is that of antibody depletion studies to selectively abolish CD8 and or CD4 positive T cell populations. What you can see clearly is that independent of T cell subtype, we lose our protective effect upon depletion, and this suggests a critical role for T cells in mediating the combinatorial protection. So now I want to shift gears very briefly to discuss another one of our projects, which is taking FUS directly to the site of metastasis. For those who are unfamiliar, CAR, or chimeric antigen receptor T cells, are a burgeoning class of cellular immunotherapies, and they've seen astonishing success in hematological cancers. In solid tumors, including breast cancers, and in this case, their brain metastases, that success has been largely limited by numerous barriers as displayed in the right-hand figure. So our group is evaluating whether mechanical focused ultrasound stimulation in conjunction with microbubbles can play a role in overcoming these barriers. And the basic principle behind this regimen is shown here. We're applying low-intensity focused ultrasound waves transcranially in combination with intravenously administered microbubbles, otherwise thought of as acoustic amplifiers, as you see in the animation there. And these essentially serve to amplify the mechanical stimulus and induce transient blood-brain and blood tumor barrier disruption. Some representative MRIs of tumor-bearing mice on the right show you what tumors and their surrounding tissue typically look like after this procedure. And what I will say is that we've been basically putting this procedure to the test, combining FUS-mediated barrier opening with a clinically relevant formulation of human CAR T cells for the treatment of unifocal breast cancer brain metastases. Notably, these studies are with a subclinical dose of CAR T cells, as evidenced by the lack of stratification between the blue and the gray curves shown here. Now what we've done is we've combined CAR T cells with focused ultrasound, and you can appreciate from the purple line that we see a robust growth control effect, suggesting that some direct or secondary impact of the barrier opening procedure is invigorating CAR T cell penetrance and or activity. To drill down on the alliance between FUS and CAR T cells, we've again been performing deep immunoprofiling, and I only have time to show a few snapshots of what we're learning. The first question, of course, was, do the T cells make it to the brain? And indeed, what we see by histology when we look at brain tumors and accompanying CD3 staining is that there are significantly more CAR T cells in the tumors of FUS recipient mice, and you can see this quantified on the right. We've also performed serial peripheral blood sampling to see if we can glean anything predictive about the nature or kinetics of the T cell response. Here, I just highlight that we do see a significantly greater proportion of circulating T cells in FUS recipient mice. You can see that on the far left. In the middle figure, we also see that these T cells are more functionally active, as denoted by their expression of granzyme B. And finally, in the figure on the right, we can see from an ongoing study that there are also early glimpses of what look to be a collective corroboration of our findings by the potential improvement of survival in mice receiving the combination of FUS and CARs. So while I would love to share more, I will go ahead and leave you all just with a few concluding thoughts here. The first being a reminder that our work in breast cancer is far from over. We need to keep pressing forward toward a future where breast cancer treatments are more effective, but all the while as safe and burden-free as possible. And the conversation these days is encouragingly shifting much more toward from merely survival to survivorship, which makes this an exciting time to think about what comes next for breast cancer therapy. FUS technology can undoubtedly play a role in all of this. I've shown you all some evidence for how FUS can synergize with novel immunotherapies, but today's talk really just scratched the surface of the many opportunities and also many open questions that remain. As will be highlighted by today's panel, we're also best positioned to learn from translational efforts that cycle burning questions from the bench to the bedside and back. And finally, as emerging domains like FUS immuno-oncology mature, I just want to remind that we'll need to keep prioritizing dialogues on harmonizing findings and standardizing methodologies so we can chart the course toward improving patient lives as quickly and meaningfully as possible. I also want to highlight for those who are keen about learning more on the topic of focused ultrasound and cancer therapy that I recently wrote an article for the latest issue of Acoustics Today, which is really meant to be an article free of scientific jargon and accessible for a very broad audience. So for anyone in the audience who is interested, you can access this article for free on AT's website. Finally, I'll just close by thanking the fantastic members of our growing team in the Shaybani Lab, as well as our many collaborators. A special thanks to our funding sources, and much of the work that you saw today was made possible by the NIH Director's Early Independence Award. I want to thank you all for your attention, and I'm looking forward to the panel discussion to follow.
Hi, I'm Patrick Dillon, and I'm a medical oncologist at the University of Virginia. Today, I'm going to share with you an exciting application of an evolving technology called focused ultrasound for the treatment of breast cancer. As an oversimplified introduction, you can see in this little diagram how sound waves would be focused onto a tiny little area of tumor during a focused ultrasound treatment. That allows for the destruction of tumor without the need for surgical incision. And what I'm going to describe in more detail today is how we are using focused ultrasound in breast cancer and how we're combining it with immunotherapy for the treatment of breast cancers. Some applications for focused ultrasound before I get into today's treatment. You probably may already know that there are about 31 approvals for focused ultrasound, and currently there are 17 companies worldwide that have medical devices that have been approved for the use of focused ultrasound in humans. And last year, there's about 113 million in industry investments in focused ultrasound. And there are about 18 countries that currently reimburse for the use of focused ultrasound. Those reimbursements in the United States so far involve treatment of bone metastases, essential tremor, Parkinson's, uterine fibroids, and just last October, the approval for treatment of tumors within the liver. So how does that apply to breast cancer? Well, I'm going to tell you here the story of one of our clinical trials called the Breast 48 trial. And in that trial, we're combining the immunotherapy approaches with focused ultrasound. And so this diagram here is to show you that immunotherapy, which has been really important for cancer treatment since 2010's first approval of an immunotherapy called ipilimumab. So this is showing you how immunotherapy is really important in turning the immune system on to recognize tumor in the body. So what we're showing on the left of this is an ultrasound ablation of a tumor. You can see a mouse tumor there. And what happens after a tumor is ablated, the cancer cells get heated up and the cells kind of come apart, and little pieces of the cancer, the antigens or the proteins of the cancer then get sent down to tumor draining lymph nodes, which is in green on the right side of this figure. And in the tumor draining lymph node, you can see that the T cells and B cells that live there get to see the little pieces of the tumor antigens. And in that tumor draining lymph node, our T cells get educated so that they can go back out into the body and look for other places where cancer exists and then attack and eradicate cancer in other parts of the body. So that's the simplified version of what we're doing when we're talking about using focused ultrasound as an immune stimulant or immune booster. So the clinical trial I'm going to tell you about was called the Breast48 clinical trial. As you can see here, we used a device called the EchoPulse device, and this is a focused ultrasound device. And as you can see at the tip of the device is a transducer, and this is on a easily movable arm, and this is automated, and there's a nice screen so we can see what we're doing. And on the right, you can see an image of a patient comfortably being treated with an ultrasound device on the skin only, no incisions here. And so we place a device over the site of a tumor. In this case, this would be a tumor in the right upper outer quadrant of a patient. And then we can identify the edges of the tumor, and we can then heat up and ablate or burn out the tumor without ever having to use the scalpel or cut. So in the first study that we did, we had 2 arms so that we could look at what happened with focused ultrasound when given with a checkpoint inhibitor priming before the focused ultrasound or after the focused ultrasound treatment. And you can see we treated 13 patients with a median age of 53 with 3.7 prior lines of chemotherapy, so very heavily pretreated metastatic breast cancer patients that were on average 2.5 years from their diagnosis of metastatic disease. And they had all kinds of organs involved, including liver, lung, bone, brain. And so a very heavily pretreated set of patients, but a very motivated set of metastatic patients who were interested in finding out how focused ultrasound and immunotherapy together would help them with their breast cancer. So the first little bit of result we saw was to do biopsies of patients at baseline and then after the ablation of their tumor. And what you can see in these IHC images here are our baseline H&E images, and then after ablation in the fully ablated area in the middle, and then in the sort of peri-ablated area right outside the zone of ablation done by focused ultrasound. And what we're looking for is an increase in little brown cells. So those are our CD8 cells. And so in our peri-ablated areas, we saw a nice increase in our number of CD8 cells, as well as increase in PD-L1, suggesting that we significantly increased the immune recognition of tumors by the application of focused ultrasound. We think that is partly what leads us to see some encouraging clinical results. So when we talk about clinical results, we talk about things like progression-free survival. And in this group of 13 patients, we observed a median progression-free survival of 4 months and a median overall survival of 18 months. So those survival times are similar to other clinical trials in 4th-line therapy or beyond for metastatic breast cancer. And excitingly, this treatment with focused ultrasound and pembrolizumab was generally considered to be very safe. And so these very heavily pretreated patients were able to have an immunotherapy that appears to be beneficial and did not involve all the side effects of chemotherapy, which they otherwise would be receiving. So patients did not lose their hair, did not have nausea, vomiting, and did not have the weight loss and hospitalizations and complications you would expect with chemotherapy. So an encouraging first piece of data in the treatment of breast cancer with focused ultrasound. And then just to give you a little hint of what's to come, so our future direction is now an ongoing trial called the Breast54 trial of focused ultrasound plus a low-dose gem as an immunotherapy. Here is the schema with 3 arms for patients with early stage disease. Now, instead of those very heavily treated patients, now we're looking at very early stage breast cancer. And we'd be looking at what happens with, again, focused ultrasound with or without an immune stimulator called low-dose gemcitabine. And the other little teaser here is I'm going to show you in the little red dots the areas of a tumor that we have targeted and ablated. And then here is after we removed the tumor surgically, and you can see nice yellow fatty tissue in the breast, and then ablated tumor tissue, which is now necrotic after we've treated it with focused ultrasound. And in our pathologic specimen by H&E staining, you can see what normally would look like viable tumor kind of in the purple here, but here in the middle, you see all this dead necrotic pink stuff, again, showing that we ablated tumor, and then also that we have a nice rind of T cells right around the ablated zone. So we think that's encouraging data for prelim treatment. So in summary, I've told you today that focused ultrasound plus immune therapies provide some early evidence of combined activity against breast cancer in metastatic patients. We have showed that this appears to be reasonably safe in heavily pretreated metastatic patients. And I've told you a little hint of early activity of focused ultrasound plus gemcitabine in early stage breast cancer patients. It looks well tolerated to date, and we're very much looking forward to seeing how patients do with this treatment in the future.
Great. Thank you for those amazing presentations, everybody.
Before I begin the question and answer portion of this program, I want to congratulate all four of you and your labs on your brilliant work. And Patrick, to use your words, this is all so encouraging. So thank you. So Andrew, I'm going to start with you. Can you discuss which biomarkers you're evaluating to help decide which patient populations would best benefit from your ADC?
Yeah, thanks very much for the question. Currently, the way that we think about utilizing trastuzumab deruxtecan in clinic is based on immunohistochemistry, so basic staining that's performed for all patients for HER2. But we know that there are probably more quantitative and more sophisticated ways that could help define which patients may optimally benefit from therapy. So we're looking at doing a form of mass spectrometry to basically have a much wider and quantitative spectrum. And we think that doing that assessment in tissue at baseline will help define more in a more sophisticated way patients who will benefit from therapy. And in addition to that, we're also looking at various markers in the blood through circulating tumor DNA, and specifically looking at the ERBB2 or HER2 gene and amplification changes over time.
Terrific. Thank you. Paulina, for your work, will your antibodies work against all types of breast cancer, HER2 positive, ER positive, and so forth, triple negative?
So that's a great question. And we don't know yet because we just did a phase 1 clinical trial and we had different cancers, not even just breast cancers in this trial. The patient that I've showed you, patient 14 that responded so well, she was actually an ER positive patient. And we've had some triple negatives in the trial, but they were in lower dose groups and they did not respond as well. So I think the only way to answer this would be to start a trial that would answer that question. Unfortunately, we also can't model it very well in mice because we don't have enough tumor cell lines that can recapitulate the different disease subtypes that well. So we're using the models that we do have. Personally, I think that the subtype wouldn't necessarily would make a change because we're trying to reinvigorate the immune system to fight the cancer. So we don't really even care what type of cancer it is, let alone the subtype. We've seen response. Our other responder was a melanoma patient, and now we have a bladder study that we have great responses in. So because we're focusing on reinvigorating the immune cells, we don't really care about the subtype at this point.
So to that point, then I imagine there is not currently a plan for a separate clinical trial in breast, or is that something that you're hoping to get to eventually?
We hope to get to all cancers eventually. The problem right now is obviously that clinical trials are very expensive and they're very complicated. And we are just an academic lab, so we have to rely on collaborations. But obviously, now that we're completing our other bladder trials soon, and we hope to expand for other cancers. So maybe breast cancer would be one of them for sure, especially the subtypes that don't have as many treatment options, the more aggressive ones. But we hope to gain some knowledge from the bladder trial in terms of understanding which patients are more likely to respond. Do they have to have specific characteristics in their pretreatment biopsies or any other markers? So we hope to be smarter after the current trial concludes, and then potentially we can open it for other cancers, including breast.
Terrific. And then my last question for you before I turn this over to Susie is, for the antibodies, do you need a direct injection? Can you inject IV? Can you encapsulate them and release them into the tumor? Can you tell us a little bit more about that?
So we do need a direct contact with the tumor. When we tried to do it systemically, it just doesn't work well enough. And I have another project with another type of cancer. Even just administering close enough to the tumor is not good enough. I didn't show it just because of time constraints, but we see that when we inject into the tumors, we see this phenomenon called tertiary lymphoid structures and an influx of immune cells into the tumor. And it seems like we need this in order to kickstart the anti-tumor immune response. So surprisingly enough, there are so many patients that have lesions that we can access either directly, like the patient that I've shown you, because she just had lesions in her underarm, or we can do a lot of the times intratumoral administration with guided ultrasound, or in the bladder study, we just admitted into the bladder itself using a catheter. So while it is a barrier, it's not as big of a barrier as I thought it would be initially, because there are a lot of accessible lesions, especially in metastatic patients.
Thank you. Susie, I'll turn it over to you.
Thank you. Thank you. I think that starts a larger conversation now to involve the whole panel. Natasha, it seems as though your work with various mechanisms of action of focused ultrasound could play a role here. So as Paulina was saying, she's doing the intratumoral injection. And we had someone from the audience ask about low intensity focused ultrasound and whether you think that could possibly help increase delivery of these antibodies directly to the tumor, which plus or minus focused ultrasound could then incite a more robust immune response for the abscopal effect. But can you talk about envisioning how other methods of focused ultrasound could possibly help make this a completely incisionless procedure?
Yeah, Susie. So thank you for the question. And I just want to say how inspired I've been by everybody's talks. Something we love doing in our lab is sort of juxtaposing that immunological benefit of FUS with the direct impact to delivery. So to the question that was asked, we've been actually doing some of that work in the lab, which I didn't show today, where we label agents like the CD40 antibodies or other assets with radionuclides and basically do immunopet imaging to track where they travel to, how long they stick around. And, what we're learning, what we're really trying to interrogate is in part where that threshold is between, like the benefits versus the deleterious effects of something like ablation for direct therapeutic penetrance. And then, with the LIFU regimens, whether microbubble assisted or not, I think then there are like yet a different set of questions that are analogous to that. So we are, if the question was about the CD40 work, we've mostly been focusing on ablation, but we'd be very interested in and may soon transit things over to thinking about microbubble assisted regimens. And then I will add that for the brain work that you all saw, we also have some parallel work going on with the CAR T cells where we're doing applications of FUS and CARs in primary breast tumors. So I think I will just make a shameless plug here for theranostic techniques, because I think, the power of being able to image and understand where these therapeutics fundamentally need to act to exert their effect is going to be really powerful for then understanding where to integrate focused ultrasound.
That's super interesting. And in the work with the CAR T cells, can you share with us how much increased delivery of the CAR T you were able to get to the areas sonicated with focused ultrasound compared to the areas without focused ultrasound?
We are going to answer that question very soon. Sadly, like we sort of, it rarely happens in science where you kind of get to like that moonshot data set first. So we have seen efficacy and now we're sort of actually reverse engineering in a rare instance in the lab to understand what we did. And so I hope to have an answer soon. The histology clearly shows there are more T cells, and I would love to get more of a volumetric sense for how that corresponds with the sonicated regions. Again, imaging is going to help us in charting that course, but I unfortunately couldn't tell you like what exactly the fold increase was in T cell penetrance or how that corresponded with the sonication. But again, very interested in going there.
Yeah, thank you. Thank you. Patrick, you ready?
Yeah.
There was a question about whether you do the focused ultrasound to the primary tumor or the metastatic focus and whether it makes a difference in the immunologic response. Some patients may have already had their primary breast tumor or most of them removed in the case of the metastatic patients that you took care of. So can you comment on whether it makes a difference if you do the FUS to the primary tumor or a metastatic focus?
Yeah, that's actually a really important question. And some of that question is still being investigated at multiple levels. As a bit of background, we definitely find immunologic differences between primary tumors in the breast and metastatic sites of disease. So the immune milieu, so the T cells, myeloid cells, B cells, the fibroblasts, even the people talk about, what kind of cytokines and other aspects of that immune microenvironment. They're very different between a primary breast tumor, a lymph node, and a distant site in the lungs, liver, bone, for example. And so we, in our first trial, I was telling you about that breast 48 trial where we used a combination of pembrolizumab and focused ultrasound. Some of the lesions that we targeted were in the axilla, so in lymph nodes. There were some deposits kind of in the soft tissue of the chest wall or of the axilla. And oftentimes when we think of a skin or a soft tissue deposit of disease, that acts more like a metastatic site of disease, meaning that we do see a much more advanced and much more immunologically altered and in many ways an immunologically suppressed or tolerogenic environment, meaning that immune therapy in the metastatic sites of breast cancer is proven to be a difficult challenge to treat. Part of the reason why we decided to do the trial in the first place was because we've had such a hard time achieving success with immunotherapy in breast cancer. Breast cancer, as many of you know, lags behind most other solid tumors in that we have absolutely no immunotherapies approved for estrogen receptor positive breast cancer at all. And we only have a first line approval in triple negative subset of breast cancer that's PD-L1 positive. So very, very limited activity of immunotherapies in either the early breast cancers or the late metastatic sites of disease. So I think as everybody on this conference has pointed out, there's a huge need for immune therapies in all stages of breast cancer. And the hope is that combinations of things like CD40 agonists, delivery techniques such as we said, intratumoral injections, focused ultrasounds, perhaps augment delivery of agents or to augment the immune environment when combining with agents. I think all those are possible ways that we might see better success in the future, but there's a lot of work yet to be done.
Thank you for that answer. And that brings me to a question for all of the panelists, because you've all alluded to how important it is to go and bring the research from bench to bedside and then back again. And I think you all have done that so efficiently and in such a great progressive manner. So maybe you could help kind of further explain how that works and how the researchers interact with the clinicians. And if you find problems or issues or spurious findings in the clinical studies, you go back to the lab and research it again. So maybe the panelists can kind of share their experiences with that in these clinical trials you've designed.
Sure. Since I'm still unmuted, I will go ahead and first and say that many of the times for me as a clinician, when I see a problem that needs solving, that's something that we talk about in joint conferences with our lab colleagues. And indeed, the trial that we're doing right now is something that's been spurred by back and forth between the clinicians and the lab group. And some of the findings from mouse study are now being examined in this current Breast54 combination of gemcitabine and focused ultrasound. So the keys, I think, to making those interactions work is having or generating time for people to sit down together and share ideas and sort of cross-pollinate different areas that might not otherwise be talking to each other and hearing what are the problems and what are the areas of advancement. So I'm sure I'd love to hear perhaps from one of the folks in the lab if you've had similar experiences trying to meet up with clinicians.
Polina, do you want to share your experiences?
Sure. So I'm only in the lab, but we have clinical fellows that have a dual appointment with our lab and Memorial Sloan Kettering because they're physician scientists. So for instance, with the story that I showed about patient 14, we had the clinical trial, and a lot of the preclinical development was actually done in other models for melanoma and colon cancer. But since we had quite a few breast cancer patients, we started looking into breast models in mice. And then when we started seeing this great response in some of the patients, we did biopsies on the patients, and we saw those TLS structures inside the biopsies and the shrinking tumors. And we always would just take the tumors of the mice and we would use them for flow cytometry, single cell, stuff like that. And we never really did stainings. And then we started doing those stainings, and we saw, can we even model those structures in mice? And TLS have been historically very difficult to model in mice, so we weren't very hopeful. But then we had, sadly, I didn't have time to show, but when we had that bilateral tumor challenge, when we had 2 tumors and the 2 memory fat pads of those mice, and they were both shrinking, but the TLS structures were only found in the injected tumor. So then we realized that maybe we're kickstarting some process in the injected side, and the non-injected side was also lagging a little bit in terms of the anti-tumor response. So this taught us a lot of things, and we wouldn't have ever looked at those structures or doing those sections if we didn't have that crosstalk with the clinicians. So this is something that is so important, and everything that our clinicians observe in the trials, we try to model it in mice, and we're trying to use our mouse models to predict the side effects that we might observe in patients. And we actually, as I've described, our humanized mouse system has been very helpful in modeling some things that we see in the clinic, and was helping us much better actually than the primate studies that we had to do in order to start the phase 1 clinical trial. So that crosstalk is really something that we must do all the time. And for us, we're lucky to be in close proximity also to Sloan Kettering and our clinicians that have that dual appointment.
And thank you for that. And just to finish up, some final thoughts from Natasha on the preclinical side, and then Andrew on the clinical side. But Natasha, how do you feel about the bench to bedside and back again concept?
Of course, I'm a huge fan of that paradigm. And I think it's critically important to leverage that paradigm deliberately, in terms of designing frameworks, as was mentioned, at the bench side that are practical and feasible to translate to the bedside. So we're very fortunate to sort of be right at the center of that crosstalk. And we check in with our clinicians early and often, folks like Dr. Dillon included, so that we're really making sure that if there is a critical juncture that we reach at the bench where we could choose to do something that, dare I say, is very scientifically interesting but less clinically relevant versus something that really does bear relevance to what patients will go through, 10 times out of 10, we're going to choose to do the latter. And so that really does result in important decisions at the bench. Conversely, I think what we learn at the bench a lot, or at the bedside, a lot was already said about that, but I will just emphasize, I think any preclinical researcher in cancer that you speak with would attest to the fact that all of our preclinical models are limited in some way. No model is perfect, but I think being very deliberate about optimizing for and enriching for models that will fundamentally recapitulate specific phenomena in the clinic, that can be very useful. And so when I say bench to bedside and back, I think some of that reverse engineering, reverse translation is really well served by starting with what we're discovering in patients and then working our way backwards, either for mechanistic interrogation or otherwise. So I think it's critical, but I will also say that you do have to be well positioned to do that. And I fully acknowledge that not every institution or hospital is necessarily able to fully execute that paradigm. So external collaborations can be really critical too.
Thank you for those thoughts. And Andrew, 30 seconds, final thoughts?
Yeah, to echo what people have said, I think some of the best science comes out of multidisciplinary collaborations. And I think it's really hard to have a model for every scenario that we're going to be testing in the clinic. So in the trial that I described, our models started really in breast cancer, and that ultimately led to a phase 1 clinical trial where we evaluated the drugs both in breast cancer patients, but also in other solid tumor types. And that led to some really interesting findings in certain GI gastrointestinal tumors. And based on those clinical findings, we then went back to our collaborators in the lab to generate some gastrointestinal PDX models. So I think that this crosstalk is really essential way to really generate innovative, impactful science.
Well, thank you for those important final thoughts. And this concludes today's webinar. I want to thank Yanni and Breast Cancer Alliance for co-sponsoring this webinar and continuing to foster collaborations. I also want to thank the Focused Ultrasound Foundation staff, Paige and Joe, to help coordinate this event. Dr. Vadensfeld, Davis, Shaybani, and Dylan, thank you so much for your time and dedication in educating us about your most interesting research with immunotherapies. And between the webinar planning sessions and this live webinar, these researchers have developed a camaraderie where they can contribute to share ideas and combine knowledge and expertise to devise creative approaches to help treat breast cancer patients utilizing the power of the immune system. Yanni?
Thank you, Susie. It is a privilege to collaborate and produce such important high-quality educational programming. I learned so much. You're all phenomenal. For those of you who joined us today, if your question was not answered, or if you would like more information about either presenting organization, you can visit breastcanceralliance.org or fussfoundation.org, FUSfoundation.org, or you can email us at info at either of those links, and we will get back to you. But thank you all for joining us, and please stay tuned for more collaborations, newsletters, and invitations to future events.
Thank you, everyone. Have a great day.